print mine out larger, but thank you. Well, good afternoon. Good afternoon, everyone. Fantastic. One more time. Good afternoon. Yes, thank you so much. Thank you so much. It's so wonderful to have each and every one of you here. Hopefully we can turn the music down just a moment. My name is Dr. Karen Wingfield. I'm the Executive Director of the Meharry-Vanderbilt Alliance, and we're so thrilled to have each and every one of you here today to help us honor the legacy of Dr. Clifton Meador. Dr. Meador actually served as the founding director of the Meharry-Vanderbilt Alliance. As you know, this is a strategic partnership between Meharry Medical College and Vanderbilt University Medical Center that's been in existence for over 20 years. Next year, we're actually going to be celebrating our 25th anniversary, so we are excited for that. Yes. And I'm very honored to actually have Dr. Consuelo Wilkins, who was the second executive director. Dr. Wilkins, thank you so much for being here as well. I know there are many of you in the audience who knows Dr. Meador a lot better than I do. Unfortunately, he passed a couple of years ago, but he was dedicated. He dedicated his life to improving health outcomes for historically excluded populations by providing and advocating for quality health care in marginalized communities. And from what I understand, he was a very humble man. He didn't brag about the things that he was doing. He just did. And that really is the spirit that hopefully we all can continue to not only celebrate, but also to start to allow to seep into our souls, just doing the work because it's important to meet the needs of the communities we serve. And so my hope is that today you'll be able to see the impact, the legacy that Dr. Meador has had through today's programming. I would like to recognize Ms. Ann Meador, who's here, Dr. Meador's wife. Thank you, Ann, for being here. We appreciate you. We appreciate your support, and we continue to enjoy every time that we get to see you. Thank you so much for being here. We really appreciate you. I'm excited that we're going to have Dr. Shanita Hughes-Halbert as our keynote speaker. You'll hear a little bit more about her later today, and so we're pleased about that. We have our Safety Net Consortium group. Who are members of the Safety Net Consortium? Can we see you? All right. Thanks, David. Rhonda, fantastic. The Safety Net Consortium of Middle Tennessee has been doing a wonderful job of also trying to improve access to care in Davidson County and beyond, and we're excited to have Dr. David Posh. You saw his hand up. Rebecca Leslie, who actually leads the organization. I don't think she's here to, is Rebecca? Yes, oh, there you are. Fantastic, great to have you here, Rebecca, and Kelly Blankenship, who's also around, so we want to thank you. And Dr. Rhonda Switzer, who raised her hand, she's going to be getting an award today, and so we're excited to be able to celebrate you and the work that you're doing to provide dental care and also with your crew for marginalized populations. So we are going to hear so many wonderful things. We have Dr. Susan Eagle in the room over there. Thank you, Susan, who is be our recipient for one of our inaugural awards for individuals who've really gone out of their way to mentor students in a very meaningful way, and so we're very, very excited. So normally what we do is we kind of do our event and then we thank the people who have been able to put things together. Today I want to move that just a little bit differently. Christopher Smith, who is our program manager of community engagement. Christopher, I just want to congratulate you on a wonderful event. Thank you so much. Let's give him a round of applause. At the Meharry-Vanderbilt Alliance, we have program managers who have been doing extraordinary work in a time where we've been extraordinarily short-staffed. So I want to recognize all of the MVA. Would you mind standing up? I see Mercedes is over there. We've got MVA staff in the background, Calandra, Fernica, yes, Audrey, brand new, Virginia, thank you. Thank you, thank you, thank you. I just want to appreciate each and every one of you, and really thank you, Chris, for putting together a wonderful event. I'm now actually going to welcome Chris up, and he's going to take the program to the next level. Thank you, Chris.
Good afternoon, everyone. I am Christopher Smith, the program manager for community engagement, and I have the honor today of recognizing our award winners for the Clifton K. Meador Health Equity Virtual Poster Competition. Before we do that, I do want to read a brief blurb about what this virtual poster competition represents, and then we will get straight into recognizing the awardees. Dr. Clifton Meador dedicated his life to improving health outcomes for historically excluded populations by promoting and advocating for quality health care in marginalized communities. This poster session honors Dr. Meador's legacy by showcasing research that embodies his vision of equitable and accessible health care for all. Posters that reflect research and/or programs dedicated to improving access to quality health care for marginalized communities are eligible for submission. At this time, I would like to welcome Dr. Wingfield and Mrs. Meador to stand at the award table to present the awards to our awardees. In third place, we will start with Ashley Dringler from Vanderbilt University School of Medicine for her poster presentation, Federal Nutrition Assistance Programs and Ultra-Processed Food Intake Among Low-Income Latino Preschoolers. Give her another round of applause. Thank you. In second place, we have Samantha Benjamin from Meharry Medical College for identifying health metrics to guide equitable care in radiation oncology. All right, and in first place, we have Ian Ely from Vanderbilt University Peabody College for increasing capacity and well-being when moving beyond the benefits cliff. And I would like to note that each one of these posters are outside in the foyer for you to see, and there's a QR code on that board as well where you can scan to see the actual video presentation. So please make sure you take the time to do that. And at this time, I will now pass it over to Mercedes Reidinger.
Hello, I am Mercedes Reidinger, Program Manager at the MBA for our Interprofessional Education and our Student Alliance programs. I have the honor of presenting the awardee for the first annual Meharry-Vanderbilt Alliance Faculty Commitment to Student Excellence Award. This award provides an opportunity to recognize faculty from Meharry Medical College or Vanderbilt University Medical Center who lead student interest groups for trainees outside of their own institution. The faculty not only exhibit a strong commitment to teaching while serving as a role model to students, residents, and trainees, but have also excelled in this responsibility. This award is unique as a faculty being recognized must be committed to student involvement at an outside institution. A professor of cardiac anesthesiology at Vanderbilt University Medical Center, the 2023 recipient of the MBA Faculty Commitment to Excellence Award is Dr. Susan Eagle. Oh, you want me? And now I would like to introduce the chair of the Safety Net Consortium of Middle Tennessee, David Posh.
Thank you and good afternoon. The Clifton Meador Community Health Equity Leadership Award is given to honor an individual in the community whose leadership and accomplishments have contributed significantly to improving access to quality health care for low-income, uninsured persons in Nashville and the surrounding areas. This award is presented in partnership by the Safety Net Consortium of Middle Tennessee and the Meharry-Vanderbilt Alliance and the Nashville Academy of Medicine. The award is given in the shape of a globe to honor the global mindset and far-reaching impact of the work that is done in our Nashville community every day. This award is given to one individual who has provided excellent contributions to advance the mission of the Safety Net Consortium of Middle Tennessee, specifically with a focus to further the work being done to serve the uninsured in our community. The award was named in honor of Dr. Clifton Meador, who was also the first recipient of this award. And you all know his legacy that we have here. With that, I'm very pleased to announce that Dr. Rhonda Switzer Nadazzi is this year's award recipient. A little bit about Rhonda. Rhonda was born in Treherne, Manitoba, Canada, and graduated from the University of Manitoba with a doctorate of medicine in dentistry degree in 1991. She completed a postgraduate residency program at the VA Medical Center in Louisville, Kentucky. Since then, Rhonda has spent her entire dental career overseeing the dental programs for the poor. She served as the head of dentistry at the Fly-In Health Center in the subarctic location of Churchill, Manitoba, the polar bear capital of the world. And that was from 1992 to 1994. She also worked as a staff dentist for the Department of Health in Hamilton, Bermuda in 1994 through 95, where she treated children of low-income families, people with mental disabilities, and people in nursing homes and prisons. Dr. Switzer Nadazzi became the first employee of the Interfaith Dental Clinic in Nashville, Tennessee in 1995, and has served as a leader since. During her tenure, the clinic has grown from a 2-chair operation located at United Methodist Church on West End. It was in the basement there. And now it is a 26-chair facility with a staff of nearly 50, caring for more than 3,000 patients annually. She was recently inducted into the International College of Dentists, an honor reserved for the top 3% of dentists worldwide. Dr. Switzer Nadazzi is a past president of the Nashville Dental Society. She chairs the Council on Oral Health Initiatives of the Tennessee Dental Association, founded and chairs the Middle Tennessee Oral Health Coalition, and now has a seat on the Council on Access and Interprofessional Relations of the American Dental Association. Katina Baird, one of our members of the Safety Net Consortium and who leads the Matthew Walker Health Center, and who also was last year's award recipient, nominated Rhonda. She expressed well Rhonda's contribution to the care of the underserved, stating that Rhonda's leadership is changing the trajectory of how we handle uninsured dental patients in Tennessee, starting with the Smile On 60 program, organizing safety net programs, providing leadership in getting pregnant women dental coverage. Rhonda champions access to the underserved and the uninsured, medical and dental equally. She seeks partnerships in the safety net and among private for-profit organizations to serve those in need. Rhonda is an innovator and a great team player. It is my pleasure and honor to recognize Rhonda, a colleague and a role model in serving the disadvantaged of our community. Rhonda, congratulations. I think we have the globe over here.
I'd never turn down the opportunity for a mic. I am so honored by this. Dr. Meador was a wonderful role model to me and a good friend, and was a huge cheerleader for oral health, making sure that my voice was always heard in all those rooms. So the work will continue. I want to shout out the interfaith team that's here today, and so many in the room that do everything collaboratively in this effort. So thank you.
All right, and now for the moment we've all been waiting for. I have the distinct honor of introducing our keynote speaker today, Dr. Shanita Hughes-Halbert. The goal of Dr. Hughes-Halbert's research program is to improve the precision of multi-level strategies for achieving health equity by identifying diverse determinants of minority health and cancer health disparities, by translating this information into sustainable interventions in clinics and community-based settings to improve cancer outcomes and chronic disease management in disparity populations in local and regional geographic areas. Dr. Hughes-Halbert is a nationally recognized expert in cancer prevention and control among diverse populations, and her research is supported by numerous grants from the National Cancer Institute, the National Institutes on Minority Health and Health Disparities, and the Veterans Affairs Medicine Center. Previously, she was a member of the Board of Scientific Advisors at the National Cancer Institute and the National Human Genome Research Institute Advisory Council. Dr. Hughes-Halbert is a past recipient of the AACR Distinguished Lecture in Cancer Health Disparities Award and is a member of the National Academy of Medicine. Please welcome Dr. Shanita Hughes-Halbert.
Well, good afternoon, everyone. It is my distinct honor and pleasure to be here today, to be a part of the honoring the legacy of Dr. Meador. One of the things I think is important for you to know is, I've had fantastic conversations today, but this is really a homecoming for me. I have been coming to Tennessee my whole life. My grandparents live in Clarksville, Tennessee, so it's truly special honor for me to be here and spend some time with you today. What I wanted to talk about is the work that I've been doing related to behavioral science and really how we think about addressing minority health and health disparities through transdisciplinary partnerships. I started my career many years ago following graduation from Howard University, and spent my formative years in Pennsylvania at the University of Pennsylvania, where I really developed a strong appreciation and value of working collaboratively across disciplines within academic medical centers, community-based organizations, and public health groups to really think about how we can improve upon all of the work that we're doing by bringing and combining our expertise. I think this is a really important and critical time in the sort of spectrum and evolution of minority health and health disparities, because we're just acknowledging and recognizing that disparities can be experienced by individuals in a number of different ways, both in terms of their racial and ethnic background, their socioeconomic status, their gender, disability status, and where they live and work and receive health care and public health services. So really, health disparities, I think, as a field and as a science, is becoming more inclusive of all of the different ways and all that the disadvantages can be experienced because of the characteristics shown here. As a result of the complexity and just a recognition that, we have to be mindful about where we live and how we live, our interventions to address minority health and health disparities are moving what we call upstream. So trained as a behavioral scientist, I typically think about sort of how we can help individuals improve their diet and physical activity, how they can improve their interactions with healthcare providers. But it really operates within a broader system that is shaped by our neighborhoods, our communities, and a variety of issues that we sort of think about as the social context. So one of the things I think has been really important for us to recognize at this point in time is that interventions are sort of moving what I call upstream, and this is illustrated in the slide here where, we've typically focused, and my own work has focused on addressing sort of immediate health needs, and we can think about that in terms of health behaviors and risk exposure behaviors. But now we're really thinking about and developing approaches for addressing broader issues such as the quality of housing, food systems, and unemployment. And then we're even thinking more broadly about how we can address sort of those systemic issues that still exist in our society, such as structural racism and exclusion. And I want to make the point, and you already know this, but I want to emphasize that it will take all of our expertise through transdisciplinary partnerships to address these complicated factors across the entire spectrum. What's been really important is that our thinking and framework for how we think about these upstream level determinants is we now have a better framework to share and to sort of come to the table with our understanding. And I was so excited, to see the Healthy People 2030 acknowledge that, our goal now is to create social, physical, and economic environments that promote all of us attaining the full potential for health and well-being for all. One of the ways that we're thinking and talking about this now is within the framework of social determinants of health, which really sort of reflect, where and how we live. In my early work, while a young assistant professor at Penn, one of the breast cancer patients that we were talking to as part of our qualitative work said, cancer is one of the things that I have to deal with in my day-to-day life. And I think now we're beginning to acknowledge that and value that perspective and begin to think about, what are the consequences of that? Sort of this whole spectrum of stress, financial resource strain, and how that leads to can influence isolation and cancer and risk behaviors related to health promotion and disease prevention. So this is a more complicated, bigger system that I think we all have to grapple with as part of our transdisciplinary teams. And this is even more pronounced as we've seen national examples of some of the systemic ways in which particular groups can be disadvantaged and experience racism that leads to whole downstream consequences in terms of issues related to employment, dealing with the legal system, the courts and schools. So all of this, these systemic issues really mean that we have to come to the table, and we have to come to the table to engage in collaborations and partnerships so that we're working collectively and leveraging all of our expertise to address these systemic issues. I also want to just acknowledge that, these conversations around race and racism and discrimination, I think have sort of long been recognized, and I'm excited that we're now finally at a point in our time and certainly within my lifetime in a professional setting, where we can talk about these issues and we have models and frameworks to help us understand them. And what I'm sharing with you now is work that was published many years ago that really just acknowledged that stress and the consequences of discrimination and other social exposures that influence neighborhood disadvantage and segregation have these downstream consequences that ultimately influence our physical health, our mental health, and our overall health and well-being. And I'm showing you this slide because it has been really formative for me to begin thinking about this from this particular framework, because it brings the conversation to our forefront of our minds about how we're living and working and how the broader environmental context and social context influences these downstream effects. We're getting more precise with our ability to sort of reflect that in our conceptual frameworks and ultimately the studies that we're doing. And what I'm showing you now is, a recent framework that was developed by a group in St. Louis, where they've really tried to make the connection between the social political structures and the ways in which they influence the policies and the practices that happen overtly or covertly, that influence their neighborhood environments, ultimately in leading to our sort of psychosocial responses that has a behavioral and a physiological response, which then lead to molecular changes that ultimately result in racial disparities, and in this example, racial disparities in breast cancer subtypes. We now have the tools and the technology using geospatial information systems and other approaches that link these data sets to be able to understand the ways in which where you live influences the types of cancer that African American women are likely to develop. So this is a really important time because as you think about and look at this slide, we probably can identify sort of the box where we fit in within our particular background and expertise. But these frameworks are really meant to bring us all together to begin thinking about the broader framework for minority health and health disparities that they exist across multiple levels, multiple domains of influence. And as I've mentioned, my training is really sort of in that the little box that's on the individual with health behaviors and coping strategies. But within this expanded framework, it provides an opportunity for someone with my background in training in behavioral science to begin working across multiple domains of influence and bringing in and engaging in important collaborations and partnerships to really to reduce and improve healthcare quality for all. So what I want to do over the next couple of slides is share with you some of the ways in which, the work that I'm excited about, that I know that is being done here at Meharry and Vanderbilt and other places in Tennessee and across the country. And I'm going to focus on the work that many of us are doing around stress and stress reactivity, because one of the things I think that has been really pronounced about as we think about the social context and social environment is we think about the ways in which the constraints and opportunities or lack of opportunities and lack of resources can serve as a stress. So I've really been thinking about sort of this from a behavioral science perspective and thinking about, well, what are different ways in which, groups respond to stress? I mean, both behaviorally, but also from a physiological perspective. And then the second goal that I think has become a priority is thinking about, well, what are the predictors and outcomes of these stress responses? In conversations today with the students who are fantastic, I've enjoyed those conversations so much this morning. Thank you for spending time with me today. Is that we want to understand, well, what makes it possible? What sort of are the antecedents that if individuals experience the same, living in the same geographic area, the same community, the same neighborhood, can respond to a stressor in one way that can demonstrate resilience, and another way that demonstrates perhaps a lower level of resilience. And then the final question that I've been really excited about addressing through collaborations is understanding how differences in stress responses may or may not be related to differences in minority health and disparities. And I've been thinking about this from the perspective of like a basic behavioral science perspective, because it's really caused me to sort of grow and mature in my own thinking about we really have to understand some of these physiological processes and how they're manifested within different environmental contexts so that we can develop and implement and evaluate interventions across clinical settings, public health settings, and population groups. So the first example I want to share with you is work that was supported through the National Institute on Minority Health and Health Disparities and the National Cancer Institute. And this transdisciplinary collaborative center in precision medicine and minority men's health was one of the first ways in which we thought about integrating the social context systematically into our research program. We did this in a couple of ways. One, by developing a multi-regional consortium that included the institutions shown here to give us a broader regional perspective, because oftentimes before this particular opportunity, in my own work, we really focused on one community, one geographic area. But we realized that minority health and health disparities exist across all regions. And if we really want to understand and be impactful, we have to work across regions to understand the ways in which there are similarities and differences and opportunities for health promotion and disease prevention. The second goal for this consortium was to conduct translational research on multi-level drivers across in biological, social, psychological, and clinical factors. And what was really exciting at this time is that this was the first ways in which those of us at the Medical University of South Carolina who were trained in behavioral science, basic science, immunology, healthcare, clinical informatics, all came together and started thinking about, well, what are the central issues that need to be addressed within the context? And I'll share with you the context in just a moment, to improve the precision and develop approaches for precision medicine that will be inclusive and not exclusive in terms of minority men. And then finally, we recognized and valued and placed a priority on implementing approaches to develop strategies to disseminate and implement our findings into care. So one of the things for those of you who are in medical school and your public health schools, we often think about, one of the primary goals is to, publish our work and present it at a national scientific conference, and that's so important. But it's also important that we take our findings out into the settings where they actually can be impactful. So we built our partnership to include organizations that were really working sort of one-on-one, had more direct contact as a service provider within the public health space. Finally, we recognized, and this was just before I think the data science explosion took place, or the explosion that I was aware of, the data science explosion, is really we wanted to leverage all of the data that we were going to collect, that is being collected, to impact practice and public health, practice in healthcare and public health practice. So we focused on minority men's health, and one of the reasons why we focused on minority men's health and sort of thought about this within the context of a stress framework is because we know that African American men in particular experience several unique chronic and acute stressors. And as we were developing our sort of the broad vision for this goal, something really striking happened in Charleston, South Carolina, where there was an incidence of a police killing, and it impacted me. I have two kids, two boys who were really small at the time, and I was like, I really have concerns about what it will be like for them growing up in an environment where they would be at risk for a harsh adverse outcome because of being stopped by the police because of a broken tail light. It made us think about, well, what is it like to live with that sort of stress on a day-to-day basis, just always there in the environment. And that was one of the things that as a graduate student at Howard, we were really focused on, is understanding ways in which individuals cope and manage stressors that exist because of race and racial discrimination. We also know that social and psychological stressors impact the biological processes that are involved in the initiation and progression of disease. And this was really important because I think as we think about disease processes and outcomes, we think about, sort of the genetics, we think about other sort of more biological mechanisms. But being exposed to stress is I think, one of the most significant risk exposure variables that we can think about, because it impacts all of us. We all have a stress response, and it's important to acknowledge that there's been a huge amount of work that's been conducted to understand the ways in which these social and psychological stressors impact disease initiation and progression. Fortunately, we do have a tool to be able to understand that and to measure it quantitatively, and that's through allostatic load, which is it's a construct that has been around for a number of years. But there's been a resurgence of interest in allostatic load because it's a way of quantifying the physiological stress response to social and psychological stressors and the way it impacts biological functioning. And what's valuable about allostatic load as a construct, as a biomarker, is that these are data that are already available in the healthcare setting, because these are typically measured as part of a primary care visit. They can be the blood pressure, body mass index, heart rate, cholesterol, or all can be easily ascertained from the electronic health record. And I know the clinicians in the room would be like, well, it may not be that easy, but it's available. We also know that racial disparities exist in allostatic load. Several studies have shown that African Americans have higher allostatic load compared to other groups. But what we don't know is the role that allostatic load plays on disease processes and outcomes. And that provided sort of an opportunity for us to build upon the work that we had done over a series of studies where we found that self-reported stress, or the extent to which men, all men, regardless of their racial or ethnic background, but following their prostate cancer diagnosis, if they felt that they said, well, I'm unable to control the things that are happening in my life, that had a negative impact on their quality of life and in their specific reactions to being diagnosed with prostate cancer. So the opportunity for us and the significance of this work is that it enabled us to think and to use this more biologically, clinically oriented construct to understand stress responses or stress reactivity in a way that is added value to the self-reported data that we can obtain through the surveys that I was interested in developing and had sort of been developing my entire career. It really brought to the table, though, the broader question of how does psychosocial stress influence cellular stress responses as sort of the initial question. And you can see from the projects here that we were sort of addressed stress in multiple different ways, prospectively using laboratory-based assessments where we expose men to a stress test to see how they responded and to be able to link that data with their responses to a prostate cancer vaccine. Because we were using variables and information about vital statistics or biomarkers related to heart rate, body mass index, blood pressure, and other indicators that were a part of the electronic medical record, we were able to link that data with the basic science study that was being conducted to understand the tumor microenvironment as part of developing a more precise way of detecting prostate cancer earlier. And then finally, the last project was focused on, well, how can we intervene? And so vitamin D, several studies have been focused on understanding vitamin D supplementation as a way to address low-risk prostate cancer and to reduce the progression of low-risk prostate cancer. But what this study was designed to do was understand the effects of vitamin D supplementation on molecular changes in the prostate, and then be able to intersect that and integrate it with men's allostatic load and other indicators of HPA axis function or the stress response within the context of their response, the molecular changes in response to vitamin D supplementation. So I'm trained as a behavioral scientist, so of course we had a behaviorally oriented survey that we named it a social determinant survey. One, because we recognized that what we were really wanting to do as part of our work was integrate the social context into all of the studies that were being conducted as part of this transdisciplinary translational research center. So you can see we asked men to tell us about their experiences with socioeconomic stressors. We obtained data on disease-related stressors that include stage of disease, their treatment type, and what their comorbidities at diagnosis, in addition to asking them about their perceptions of stress and confidence to manage stress associated with being diagnosed and treated for prostate cancer. We also asked them to tell us about their perceived stress and their levels of social isolation. One, I think a little bit in advance of when, sort of this framework of social determinants of health really became more prominent. So we're proud and pleased that we were able, I think, to contribute to the development of this framework of thinking about cancer care and then within the context of social determinants of health. So one of the things we realized also that in order to be effective, I mentioned that we needed to have tools and resources that can be implemented across multiple settings and actually be implemented into the places where individuals are receiving care. And this is one of the first examples that I want to share with you of how we partner together through this transdisciplinary partnership and collaboration to create a tool that uses data science methods, builds upon machine learning and artificial intelligence to develop an algorithm to identify patients who have social risk factors based on the information that's documented in their electronic medical record. So this brings a collaboration together between population and behavioral scientists who provided the expertise of providing the content and the guidance about what are the social determinants that need to be identified and extracted, how are they likely to be represented in the clinical notes, together with the expertise of our machine learning and clinical informaticians who provided the expertise in developing the algorithms and the processes and the pipelines for implementing and applying those the machine learning tools to the electronic health record. And then we also, this was at a time when I think there was just a greater recognition of the physical place where one lives and being able to account for that and understand it as part of a transdisciplinary collaboration. So we brought in expertise in geospatial information systems to help us take information or apply information that was being already evaluated and already measured as part of the census processes, to be able to integrate that into our research, to be able to characterize the neighborhood and community level context that's important to disease risk and outcomes. We focused our work on sort of our work in NLP on sort of social connections, because one of the things that we I think just anticipated was that, the extent to which, and this was based on data from animal studies, which demonstrated that animals who were socially isolated were more likely to develop certain types of cancer, in this case breast cancer, that was histologically more similar to the types of diseases that develop among African American women. So their tools, they're self-report instruments that are developed within the context of behavioral science research that assess isolation, which is the number of contacts that you have with people, and the loneliness, which is the subjective measure of the quality of those social relationships. And so we, again, sort of thinking about translating findings from an animal setting into human populations, and so that was our reason for focusing on social connections and loneliness as our first sort of tool to develop for implementation into a healthcare setting. This shows you that the pipeline was developed with based on the expertise of the clinical informaticians at my previous institution, and again, it really did bring together, and I'm just reflecting now upon the conversations that we had to develop the algorithms and the codes that were used to create the NLP pipeline, to create this lexicon that could be applied and is now being applied in the VA setting to understand the generalizability and the concordance with what men actually say their levels of social isolation are, in a work led by my colleague still at the VA located in Charleston, South Carolina. But this gives you some examples of what we found. So one of the things I'll draw your attention to is that, the electronic health record is a fascinating entity in and of itself. And so I'll share with you, some of the most important conversations that we had is with providers as we were developing the lexicon. We shared with them what we were finding, and they were like, we document this in all of our cases. I'm like, well, our findings don't show that that's the case, but okay, tell us how you're doing that. And this illustrates some of the examples of the ways in which social isolation were documented in the electronic health records as part of our test data set. But it's really fascinating because you can see there's so many different ways in which social isolation or loneliness is being documented in the electronic health record. It sort of brings us back to this sort of broader framework of thinking about social determinants of health and creating more structure, I think, to how we assess that. The other thing that we did, thinking about this as a multi-level perspective, so there's what happens in the patient-provider interaction, what's documented in the electronic health record, but then there's the broader context of where individuals live. So again, this was at a time when area deprivation, social deprivation, we had the tools and the technology to be able to leverage data from the census to understand the amount of disadvantage that exists and quantify it using standardized approaches. this was work led by my previous postdoctoral fellow, who is now completing his residency in community psychiatry. And so he was interested in using this as a tool to be able to identify areas that had both high levels of social deprivation, high rates of disparities, and he's interested in breast cancer, interested in breast cancer morbidity and mortality based on race, and to sort of use that information to improve the precision of where and how we activate screening services, where and how we activate navigation programs, where and how we offer more training to our providers to improve the quality of care that they provide to their patients. So this is just showing that, in this first publication that he did was just showing proof of principle that there are differences in levels of social deprivation based on racial and ethnic background. And how this work is being continued now is that the sort of hot spots, I heard about this recently, more recently as in yesterday, but it's something that I think is growing in terms of its importance, because we're now being able to think about, well, what are the hot spots in your particular state? And we're doing that at the University of Southern California now. But for us, one of the things that we were really focused on is like, well, what are the ways in which social deprivation has manifests in terms of a behavioral outcome? And part of what we were interested in doing is this is sort of move the work from a descriptive examination of levels of social deprivation to really link it to things that are actually behaviorally oriented. Two other things that I think are really important within the space of minority health and health disparities is that we're interested in the extent to which individuals have access to and utilize the resources that are available in healthcare settings. I've talked about the electronic health record. It's consistent with that. There's been tremendous investment in making sure that individuals have access to their health information through the patient portal. There's a huge literature about the digital divide and the differences in activation of patient portal based on racial and ethnic background. And we found that in our work here. But what was also very interesting is that we found that in addition to race, social deprivation was associated with a significantly reduced likelihood of both enrolling in a study that we were conducting, but also with activating the patient portal. So what does this mean for us? So if we think about, and we've all gone through COVID where we had to sort of pivot to a telehealth, telemedicine approach. So if you live in an area where you don't have reliable internet connection or you don't have access to broadband connection, then that shapes and influences your ability to access some of the most basic things in the electronic health record. So it just makes us think about, as we move forward with digital tools and digital resources, that we have to be mindful that all of these things are implemented within a broader social context and in areas that may have reduced access because of greater levels of deprivation at the community level. I've talked about structural racism, and one of the things that we were focused on as part of this research is really thinking about there's systemic racism, structural racism. There's been so many focal ways in which we focused on this more recently. And I think one of the things that struck us as we thought about the social context and structural racism, and that it really is manifested through the lived experiences that individuals have. So yes, you can live in an area that has high levels of social deprivation. You can live in an area that has high levels of segregation and low levels of integration. But that in and of itself is necessary, but not sufficient, because really it's the lived experiences that individuals have. And what we believe is that we have to have a better understanding of the lived experiences that individuals have so that we can begin to improve the precision of the ways in which we address these issues. Because we know that addressing systemic racism is something that's going to take, that's a long-term goal. That's a long-term goal that we've been working towards for many years. So we have to begin to understand, well, what are the ways, the lived experiences, what are the levels, what does it mean for our physiological responses, and what does it mean for our psychosocial and overall quality of life? So some of the ways that we can think about lived experiences in terms of having housing difficulty, being unemployed, difficulty finding a job, violence, legal issue, reminding you that these are all things that are now within the context of a social determinants of health framework. So what I'm showing you now are data from specifically for the African American men in our Precision Medicine Center, where 80% reported at least one negative life event, and the average was 2. But I want to draw your attention to the table where we're showing that experiencing negative life events is associated with higher heart rates, more social isolation, and a lower level of quality of life. So we're demonstrating again that this broader social context has sort of this downstream effect, both in terms of one's physiological functioning and their psychosocial quality of life. I mentioned that we focused on allostatic load because it's one of the ways in which there's it provides us the opportunity to measure and understand physiological responses to stress using data that's already available in the electronic health record. There's also information where we know we can obtain these variables as part of prospective assessments that are done as part of laboratory studies. Allostatic load has been calculated through the NHANES, these population-based studies. So it really is a way of understanding the consequences of a prolonged stress exposure in a robust way across multiple systems. So we were really focused on this, as I mentioned before, but one of the things that we acknowledge is that because allostatic load includes at its most, I call it the Cadillac version of allostatic load, which is you measure all 12 of the biomarkers prospectively, and then you can reassess them to understand changes in allostatic load. And I would say that would be the most perfect study design that I would be eager to be part of. But instead, what we realize is that allostatic load is measured differently across different studies and across different clinical populations based on the data that's available. That is important because because it tells us that we can leverage the information that we have to have benefit and value. We've been thinking about this, however, from the perspective of we want to be able to understand allostatic load systematically and consistently across settings. So patients in primary care, patients in oncology care, patients in nephrology, patients across all of the different clinical divisions. And also that would be relevant for population and public health based studies. So we've developed what we call an electronic health record derived calculation for allostatic load, which is based on a couple of biomarkers that include body mass index, systolic and diastolic blood pressure, glucose, and heart rate. So 5 biomarkers that we can sort of feel with great reliability are available regardless of the clinical specialty in which patients are receiving care. And we can also incorporate that approach within our prospective studies. The first step, though, is that we have to make sure that the allostatic load variable, our EHR-derived variable, is meaningful and has validity, both in terms of how it's related to what we know in terms of and reflects sort of racial differences in allostatic load that have been reported in other settings, and that is related to actually other types of social indicators that we know is critical and important for minority health and healthcare outcomes. So what I'm showing you here is a snippet of our first findings where we demonstrated that our EHR-derived aspect of allostatic load does demonstrate significant racial differences and also differs as we would expect based on education level. But what's interesting, and this is I think an area where there's an opportunity for further exploration, is with respect to differences based on PSA, or prostate-specific antigen levels, and these were among men at the point of their pre-surgical visit for their radical prostatectomy. So it's important because it suggests that as a cumulative index, there's some association with the body's stress response and PSA levels. And so this is, I think, an opportunity where I would say we had to have more collaboration among our basic scientists and our informaticians to be able to think about, well, how can we, as we started our center, I said, I want something where we could just push a button and it creates the allostatic load variable. And that's That's a ways off, I'll say, but we're making progress. And then finally, I wouldn't be like a card-carrying behavioral scientist if I didn't share with you one aspect of some behavioral outcome. So I've mentioned that we've done work in physical activity in our previous community-based studies, but we also know physical activity is important for all individuals, particularly those who are recovering from diseases such as prostate cancer. And moderate intensity physical activity actually, and as well as vigorous level physical activity, has some benefit in terms of morbidity and mortality from prostate cancer. But what we're showing you here is that, most of the men who are treated with a radical prostatectomy don't meet the recommended guidelines for moderate intensity physical activity, and that perceived stress and having a greater level of stress is associated with the reduced likelihood of meeting the recommended guidelines. So what this tells us is that it's important for us to begin thinking about these. We can have multiple levels of measuring the same construct. So I've demonstrated allostatic load. Self-reported stress is another way of thinking about that, and then leveraging the data from the electronic health record. So we need all of these different types of indicators, which means that we need all different types of expertise as part of these partnerships and collaborations to have impact in terms of minority health and health disparities. The last example that I want to share with you is one that really holds us to what I just said, is how we're actually implementing this. So we're working across geographic areas, West Coast, East Coast, to really address lung cancer disparities, because we know that there are differences in tobacco control policies across different regions. We know that there are differences in smoking behaviors across different regions. We know that that there are, and because of these different environmental exposures, one of the things that I've been learning about since moving to California is that the physical geography of Southern California has implications for the ways in which and the level of exposure to different environmental pollutants. So those are really important differences that I think we have to be able to understand and recognize as part of our research. So we have two projects as part of this bi-coastal collaboration. One is focused on understanding the intersection between environmental stress using those geospatial information systems, and it's led by two pulmonologists. And then my project, which is really focused on understanding stress reactivity and nicotine addiction in Black and white men who smoke cigarettes. Why is this important? Because we want to be able to develop social biomarkers that are relevant to improve the precision that we're able to identify patients for molecular biomarker screening. And this just illustrates the ways in which the distribution of smoking and social stress sort of intersect in the Virginia catchment area. And then my project, which is focused on understanding, again, the ways in which social stressors, environmental exposures improve, so that we can create these sort of and use stress biomarkers as a way to improve the precision of smoking cessation and tobacco control programs. And I think this is really important, because one of the things that we often think about when we sort of try to understand minority health and health disparities is like, well, what are the rates of smoking across different areas? So I just moved from South Carolina, and African Americans in South Carolina, about 16% report that they smoke cigarettes. California has a much more rigorous tobacco control policies that have been implemented for longer periods of time. About 15% of African Americans smoke cigarettes in California. So it sort of raises the question that our policies, even though they might be rigorous, might not be reaching and have the influence and impact that we want them to have in different communities and different aspects of our population. So again, it emphasizes that we need all players at the table to begin thinking about, well, if we have this tobacco control policy, why is it not having the same benefits among groups, within this state that arguably is like, as I understand it, has like one of the best rated tobacco control policies in the country. We have to think about that. But we also had to think about that within the context of individual behavior, right? And individual markers of behavior. And individual sort of, in this case, stress responses. And that's what we're doing as part of the project that I'm leading, is that we're really understanding racial differences in acute and chronic stress responses between Black and white men who smoke cigarettes. We're doing that through using a laboratory-based approach where we're asking men to complete a couple of stressful tasks and then measure their cortisol or the stress response hormones as a result of that. But we're also asking men to tell us about their stress exposures and their day-to-day lived experiences and linking that with the reactions to our laboratory-based stress tests. I want to bring my comments to a close by saying we at the end of the day, we have to begin moving from sort of understanding determinants, drivers, to actual solutions. So one of the things that I think we began thinking about doing this is, one, as we identify sort of and evaluate biomarkers of structural racism in the structural environment using markers such as allostatic load, we translate this information into evidence-based interventions that could be at the clinical level, it can be at the community level, it can be at the individual level. And then we disseminate and implement those interventions into policy and practice. Those are the things where we have to be moving and shifting our focus. You know, I've spent the better part of my career sort of in this, identifying, different drivers and determinants. And I'll say that, I'm really excited about the aspects of translating these discoveries into the clinical setting and into population and public health practice. One example that I think is where we are right now grappling with is integrating social care into the delivery of health care. And so, as I've just said, we're now sort of implementing screening programs. We're thinking about ways in which we can adjust medical care and link patients who have social risk factors to community resources. I don't think we really know in the most comprehensive way, or the way to leverage the public health systems in the most effective way to really address the social risk factors as we identify them. So it will take all of us to come to the table to work together through transdisciplinary partnerships between healthcare settings, public health practices, to really begin to work together in partnership to improve minority health and achieve actual health equity. I'd like to thank my new team, my new lab that has shown these wonderful women shown here. So I'm super excited to work with such a powerful group of women and the other investigators at the University of Southern California. I started my comments by saying that this is a homecoming, so I always like to thank my family for supporting me in my journeys across the country. So thank you so much.
Thank you so much, Dr. Hughes-Halbert. Really appreciate you. We had originally planned to do a fireside chat, but because of time, and I know some of you have to leave, so don't hesitate. My hope is that folks will stay for a little bit, but you kind of hinted at this just a little bit. And for those of you who have questions, please line up at the mic. We'll kind of clear a pathway. I know you have to go. Congratulations again, Dr. Eagle. Really appreciate you. She came from the operating room this morning, so she's probably gonna head back. So thank you so much. So you alluded to this. I mean, we've spent a lot of time doing the descriptive stuff, right? And the implementation piece is where we are now. But part of the challenge, as you know, is much of what happens with respect to health happens outside of the healthcare system as it's currently thought of, right? Medical care itself. Can you speak a little bit to what your thoughts are about how we might start to re-envision the way that we think about health and the healthcare system in this country, and how we might be able to start to activate some of that?
Yeah, thank you. That's a great question. I have been really excited about the work that's being done within the space around community health workers and community navigation programs, because it really is a way to bridge sort of the clinical healthcare setting with the individuals who live, work, and know the community and know the systems, know how to do things in a way that we just don't know, I think, in our academic medical centers. So I'm really excited about that, and I think that's one of the ways that we can begin bridging community public health with the clinical settings. I'm excited because we're launching a social determinants of health navigation program where we're building this cadre of navigators who are really focused on social determinants of health. And they're be focused, and it's interesting because I think it'll take some education, because one of the things that, as we're developing the position descriptions and talking to our clinical navigators, our nurse navigators, is, like, well, we do that. I'm like, you do. you absolutely do. And the navigation you provide to get patients from one clinical context to the other, I think, is critically important. We could not operate without that. But what we see our social navigators doing is really bringing in the community focus and the community resources into that clinical space. And so I think that is emerging as a framework and a process. And I'm excited to be part of that in developing it, because I think that's what we need. And actually the notion of that came from work that I was doing in Philadelphia. We had community members who were part of our team, who were working as research assistants, who were sort of our outreach specialists. And one of the things they were like, we know how to do all this. You might not know how to do it, but we know how to do it. And so some of it is just, having some humility about what we know and what we don't know, and being able to, be humble and just value and respect the experiences that different stakeholders, different individuals have, and to bring those conversations and those partnerships into the table.
It's nice to see you again. We worked together on the U54, and I've really enjoyed your talk, and it just had concepts that were just very palatable and great to hear. So I think Dr. Wingfield kind of set up my question, whether she knew that or not. She talked about implementation, and I'm interested in dissemination, because you have some findings that really, have some high-level concepts. Allostatic load isn't something that we converse about at dinner tables and what have you, but I'm very interested in how you plan to disseminate your findings. And I work with a group, Cornet, and we actually have a dissemination dissemination matrix, but it seems like we need to refine it generationally. And as far as cultural norms, we know we don't want things to be behind the paywall, and that people aren't always reading these peer-reviewed manuscripts, but certainly just different ways of broadcasting information to communities in a way that they can pick it up, like anywhere from TikTok to the radio, it seems like.
Yeah, so you're absolutely right. I mean, one of the, dissemination has been, and sort of taking what we found, what's been found by other groups, and translating that into a message that is accessible to all, has been a focal point for many of us for many years. And I think the ways in which, we were doing this, 10 years ago, we used to sponsor something called a community information workshop. It was called Information, Education, and Hope. And it was bringing people, to like to this type of venue to just talk about what we're doing, what we're finding, and what we should be doing. Now, I think that model is valuable. But I think it's valuable for a certain segment of the population. And because when I've talked about it to like my colleagues who are, at less mature in their career, what they've said is like, we can reach out, Twitter and TikTok, and LinkedIn. And so there's a whole science, I think, behind social media communications that I would say for myself, I don't have the best understanding of it because it's not something that I have grown up with. But I think the model that the partnership between the University of Southern California and the University of Florida and Florida A&M, we're part of the PACHI program that's supported by the National Cancer Institute. One of the things that I have been so impressed with is that they have taken very high-level concepts and have multiple ways of communicating that to the broader community through LinkedIn, Twitter, I would imagine they have a TikTok account. I don't have TikTok, so I don't know. But that, I mean, it's been really impressive for me to see just the ways in which they take, concept, and it was not just one and done, but it's really about taking a concept and approaching it from multiple perspectives and communicating that sort of same message across multiple platforms, multiple sort of individual messages, so that are created and curated for the social media platform. So I think that's something that we all have to learn about and be able to and use in the most effective way.
Thank you.
If you have any questions, come up. We have about another few minutes. I just want to piggyback off of that. Himani Hughes, who's standing here in the corner, she's going to kill me because she hates that, but she's actually on the Meharry-Vanderbilt Alliance team as our communication specialist. And actually, we just launched our communication health education program with TSU. So Tennessee State University has a comms program, but health communication is really important. How do you reach the people? You're doing all this research, how do you reach the people who could most benefit? And so Himani has just launched it, and actually Jada, who's taking pictures right there, is one of our health interns. I don't know if Adrian is here, but he's fabulous and has been working with us on this as well. Any other questions for Dr. Hughes-Halbert? Yes, come on up.
Hello again. It was really interesting, that question, bringing up like social media and things. I'm a first year MPH student here at Meharry, so we're always talking about social determinants of health and different factors that go into, health, minority health disparities and just health disparities in general. So I think my question is, to bridge that gap in communication, I really believe that there needs to be a partnership between, like you said, people who are less mature in their journey or are still learning where they are in public health and how we as younger people can contribute to that. What are some ways that we as the younger generation can, help bridge that gap in communication? Because like you said, you may not have a TikTok, but I would say me and my classmates were well versed in TikTok and social media and things of that nature. So is there any advice you can give or any ideas that you have about how we can, collaborate and work together that way that we reach the masses? And I guess a second part to that question is, if we start early, do you think that, some things will change within the next couple of years? Because a lot of what I see issues in the community is that younger people are not well informed. And sometimes it's hard for us to digest things coming from someone that might be older than us or more experienced, because we might not feel as if we're well knowledgeable in that area. So I guess it's kind of a twofold there.
Yeah, so I'll speak again. I mean, those are great questions, and in my response, and I think the essential points is that, when we think about research, behavioral science research, any research, you really think about it as a pipeline, to my way of thinking. And some of the things I know that as part of our partnership program, we have several pipelines, but what we really don't, I don't know that we do the best job of implementing health communications as part of the curriculum. And I would say that is something that we absolutely need to do. And health communications, and really bring in the experts that understand like the science of communication. Because I think part of what I would say is that, again, we might assume that, I have a lot of experience, developing like a community information workshop. There are health fairs that we know how to do. We know how to do it really well. But I would say, probably there's an emerging science around social media. One of my colleagues at the Annenberg School for Communication at USC has developed a social media lab that focuses on health equity. And so some of the ways someone's just thinking about is, well, understanding what people are saying and how they're communicating about different issues on, on the social media platforms. And I think to the extent that we can understand it, sort of what the landscape is and where and how we need to go, I think that'll just enable us to be more effective. But I think we have to have, having the days of, things being decided upon by the more senior investigators, I think, are over. Because they should be, I think, because there's a generation that understands how to do things differently and that reflect what's actually happening. So I think, you know, the couple issues. One is that we have to be more inclusive in our and how we develop our research programs and teams. And, you know, one of the things I think is really exciting about Meharry and Vanderbilt and the Alliance is that you do have like public health, medical school, from multiple domains to really begin thinking about, you know, this is how you do things. And that's, you know, that's a lived experience that many of us just don't have.
Thank you.
Thank you.
Hello. Thank you for coming today. I really enjoyed your talk. And I'm Alexis. I'm a PhD student here. And this is honestly my first exposure to behavioral health. And so in my research, I actually study human genetics. And I understand the similarities in some of things that we would like to capture in our studies. One of those is risk for different outcomes. And your talk reminded me of a question that I heard on Wednesday at Meharry's announcement of their biorepository, hoping and trying to understand how we can connect all of this genetic and genomic information that we've come about to social determinants of health. And so I guess, I don't know if it's really a question or a comment, but really from my learning as a student, hoping to have some novel findings and hopefully to be able to do impactful research, I guess, what things should I be looking for, or how can we sort of tie in together these social determinants as well as these genetic exposures that are also associated with these outcomes?
Yeah, so thank you for that. So one, thank you for the question, because I do think we are now at a point where we begin reimagining what our data resources look like and the type of information they include. So the electronic health record is the record of truth, for instance, for clinical care. That's the record of truth. And so when you think about that, though, some institutions have moved in their thinking and the resources that they're developing to create research data warehouses that enables you to link the clinical components of care with other aspects. So the social risk factors, using GIS as one sort of geocoding patients' addresses to understand, you know, the social deprivations, or being able to create the capacity to calculate those types of indicators. So one is just sort of thinking about, well, what are the most important questions in the social environment that are relevant and important to include within those reimagined data sets? Because realizing they have there's a limit to what they can and should do. So I think part of it is bringing, you know, working collaboratively with your behavioral science colleagues and your public health professionals to think about, well, what are the issues in the context of cancer, for instance. There's work being done in epigenetics to understand the ways in which methylation influences, you know, breast cancer risk, and characterizing those based on geographic information systems. And what they've been able to do is leverage sort of the thinking about someone having a biopsy or a mastectomy, taking tissue samples and being able to do the epigenetics research and then link that back to the neighborhood level characteristics. That requires sort of multiple stakeholders at the table. I don't know that I've really answered your question because I've said a lot, but
no, I'm taking it in. It's, you know,
but it's. I guess my answer, just to summarize, would be, you know, we really have to think about, well, what are the issues, right? What are the questions that we want to be able to understand? And I think they're probably a basic set. So if you go back to the framework of social determinants of health, you know, we need to be able to think about and apply that framework into the work that's being done. So one is go back to the conceptual framework, and then sort of derive in the implementation of like your data sets and research based on the sort of the framework of social determinants of health.
Thank you.
So, Dr. Hughes-Halbert, we just want to thank you so much again for not only just your vast expertise, but really for sharing with us. Thank you so much for spending time with our students. We have a small gift for you that we'd like to actually present you with right now, so thank you so much. And I want to thank each and every one of you for being here today. We really appreciate you. We hope you'll come back next year. We're going to probably move this to an evening event, so hopefully there'll be lots of fun there as well. And want to thank again all of the Meharry-Vanderbilt Alliance staff, Meredith and our students who are sitting out there checking folks in. Thank you so much. And again, thank you all for being here today. We appreciate you.